So thank you so much for joining our webinar this morning. My name is Delaney Hines. My preferred pronouns are he, him, and I serve as the chair for the Education Committee at the SCAGO, as well as a member of the Board of Directors, and I'll be moderating today's session. If you or members of your network would like to refer to the information shared in this session following the live broadcast, a recording of today's session will be posted on our website, www.sicklecellanemia.ca. I can post it in the chat in a quick second for you all. And there you can view it at your convenience to review any of the tips or the highlights and advice that are being shared today. One of our missions at SCAGO is to serve as a conduit for members of our community to access evidence-based, up-to-date information like we have prepared for you this morning. Today's session is important because we all understand that living with sickle cell disease has its own consideration one needs to take into account, but we also want to bring to you timely information about what it means to live through another event, much like a stroke. So we hope that today provides a lot of promising clinical and lived experience information that will help you feel more informed as you continue on in your day-to-day. So we hope to be able to guide you through that effectively. So we'll be hearing from two guests who I'll introduce shortly. One, you can see their names reflected on the screen. But just before I do that, I just want to make sure I provide folks with a bit of understanding of what the agenda is. So I'm shortly going to deliver a land acknowledgement followed by a few housekeeping rules. We'll then have a presentation from Dr. Sarah Patterson, or my good friend Sarah. Following Sarah, we'll be hearing from Ms. Marlene Scott, who'll be giving you a bit more of a lived experience and perspective I think would be very, very well received. Then we'll have opportunity for question and answer, some closing remarks, and then we can bid you all adieu to enjoy the rest of your Saturday. So as many of you have already come to realize, we've muted, the session will be recorded, like I mentioned earlier, as well as muted your microphones, just to ensure we can have a nice, seamless conversation. Rest assured, at the Q&A, if you would like to pose your question orally, you can raise your hand using the raise hand feature in your toolbar, and then I'll be able to unmute you and you'll be able to speak directly to our panelists. But the Q&A feature would be the easiest way for you to take some time to collect your thoughts and insert your question. And if time permits, we'll be able to get through them all today. But we do ask that, for example, if you have any questions or concerns, please do save them for the later portion of the session. Also, within the chat, I know this is a safe space, but I'd be remiss if I didn't mention that, we do want to keep respectful language used in the chat. If you have a disagreement or discontent about what's being said, please reserve to keep that to yourself. Also, please don't post any material that's unrelated to today's discussion or topic. I want to make sure those who've signed on can experience an uninterrupted session. And if you can keep discussions and comments on topic as much as possible, that would be greatly, greatly appreciated. So we're grateful for the opportunity to gather here virtually on this land, and we thank the generations of Indigenous people who have taken care of this land long before other nations or groups came. Myself personally am joining you from Ajax, Ontario, which is the traditional territory of the Huron-Wendat, Haudenosaunee, and Anishinaabe Mississauga, adjacent to the Mississaugas of Scugog Island First Nation, all in the territory covered by the Williams Treaty. I have the pleasure of, being a son to two Jamaican immigrant parents who came here not only looking for better opportunities, but to work hard. And that was bestowed upon me, the privilege of working hard and being able to, thrive and survive, so to speak. So it's an honor and a privilege to be able to work and play freely on these lands. And I do recognize the responsibility I have to pay it forward to ensure that other generations and future generations don't have to overcome the barriers our predecessors had once had to overcome. So with that, just want to make sure we had a chance to recognize and acknowledge the Indigenous peoples of whom we should be in lockstep working to ensure their sovereignty. Before I introduce our first speaker, I'm just want to let you know that this is not meant to constitute any medical advice. What we're sharing today is an orientation or more of an, I don't want to say an academic conversation, but it's not a clinical interaction. So what's being shared with you is only for information purposes only. No materials shared with you today are intended to be a substitute for professional medical advice, diagnosis, or treatment. always seek the advice of your physician or other qualified healthcare provider whom you're working with if you have any questions regarding your specific medical condition or treatment before undertaking any new healthcare regimen, sorry. Please do not disregard the professional medical advice or delay seeking it because of something said during this webinar. Okay, that's a lot from me. I know. I know you're waiting with bated breath to hear from our speakers today. So joining me, we have first up apologies, my mouse is being a bit fidgety, Dr. Sarah Patterson. Dr. Sarah Patterson is an adult hematologist at McMaster Health Sciences, as well as at McMaster University. She comes here, like I mentioned, a long-term supporter of the SCAGO, has been near and dear to helping initiate and help contribute to a lot of the initiatives being led by SCAGO. She completed her medical training at Queen's University and McMaster, including a fellowship in red cell disorders, which was completed in 2023. She has an interest in both health policy and health equity, and is currently completing a master's degree in health systems research. And her research interests include promoting health equity and quality of care. And joining her, who will be discussing a bit more of the lived experience, is Miss Marlene Scott. Marlene Scott migrated to Canada in June of 2013 from Jamaica. She and I are both proud Western supporters. We both hail from London at one point in time in our lives. She currently lives and works in London and has been there since she arrived. She's a mother to one son and his wife, a grandmother to two grandkids. Marlene's sickle cell type is SC, and after migrating to Canada, she first fell ill in 2017 and was taken to the university hospital at that point. And based on this development, she became a patient of the Victoria Hospital's red blood cell disorder clinic. In and around 2021, the following items were discovered. She was living with a PFO. She found protein in her urine. She had an occurrence of stroke and was now basically living with borderline osteoporosis. So as a result, in addition to her hematologist, she's now under the care of several specialists. Early this year, after another stroke occurrence, it was time to take her treatment to the next level. And Marlene's going to give us a bit more insight about what that entails and some considerations we should be aware of. So without further ado, thank you so much for being so patient. I'm going to turn the screen and the microphone over to my friend, Sarah, Dr. Sarah Patterson. Over to you, Sarah.
All right, I have slides. Hopefully we can see slides. So thank you very much for that lovely introduction. I am going to talk a little bit about the complications of sickle cell disease, as well as a little bit of the prevention and the screening and how we can improve health outcomes. So briefly about treatments. I'm not someone living with sickle cell disease, so I'm absolutely thrilled to be here with someone who can talk about sort of the importance of teamwork and how important an individual's experience is and how we need to work together as a health system with people living with disease to have the best outcomes together. So that's what I hope to provide to you today. I don't have any pertinent conflicts of interest. I'm a sub-investigator for AGIOS for a pyruvate kinase study. And I volunteer for Ontario Health with some lab stuff, but none of that is pertinent to anything I'm going to discuss today. So we're here talking about sickle cell. I think most people know what sickle cell disease is. It's a mutation of the hemoglobin. The hemoglobin in the red blood cells carries oxygen around the body. And when the mutation happens and these cells change shape, they are no longer able to flow as freely through the body because that pointed shape can get stuck in small blood vessels in the body, which is one cause of organ damage. But also these cells, when they change shape like this, are cleared. They're turned over and destroyed by the body faster. So that's called hemolysis. And those two things, the change of shape of the cell, as well as the increased cell turnover, are two of the main mechanisms of why people get sick from sickle cell disease. There's a number of different mutations that can happen together, but you need at least one hemoglobin S mutation. Sickle cell disease affects the whole body, and the effects that we see are different across a lifespan. I will not be able to talk about every complication of sickle cell disease today, But I'd like to highlight some of these things and notice how the complications of sickle cell disease accumulate and they progress across a lifespan. So you can see that as a baby, there's a risk of stroke, of infections, including infections with bacteria in the blood called sepsis. As you go over towards adulthood, there's more increase in pain as a manifestation of sickle cell disease, more trouble with your bones. So this osteonecrosis or death of part of the bones. You're more likely to have eye trouble as you get older. In some ways, sickle cell disease acts as a more rapid aging process so that there's a shift towards chronic complications that we normally see in people who have advanced age happening at earlier ages in people with sickle cell disease. So there are acute complications and chronic complications. And these complications can affect people from their head to their toe. My favorite hematology quote that I've ever heard, which probably references the fact that I'm a little bit of a nerd, is that hematology is the study of blood and the tissue through which it flows. Blood goes everywhere from the top of your head to the tip of your toes. And when your blood is the thing that's causing problems, you can get problems from the tip of your head to the tip of your toes. This picture here of this non-gendered person shows the acute complications in yellow. So things like stroke and gallstones, but also things that develop over a lifetime, chronic complications like anemia and a spleen that doesn't work as we get older. As we said previously, the two main mechanisms of the complications of sickle cell disease either result from those sickled cells, that shape getting stuck in the small blood vessels of the body, or from that increase in blood turnover leading to inflammation and causing damage that way. This sounds very obscure, and I'm hoping that I can get it even clearer as we go on. I think most of us remember at one point in our life doing something active, and you've pushed yourself past the point of what was probably smart, and you get that terrible muscle pain from that lactic acidosis, if you're trying to run for track, and how painful that can be. For people who don't have sickle cell disease, that is just a drop in the bucket of the pain that people experience when your tissues, so like your legs, if you've been running, are experiencing ischemia. Ischemia is the fancy word for damage due to lack of oxygen getting to the tissues. And that feeling when you've run too hard and your legs hurt and you feel like your insides are trying to be outsides is just a drop in the bucket compared to what people with sickle cell can experience. But it's one of the ways that I try to get people who don't live with this disease to sort of understand a little bit how this happens. If you have blood flow that starts and stops and starts and stops, that can cause pain, but over a long time can cause damage and inflammation. And if you have a complete blockage for a long period of time, sometimes the tissue beyond does not come back. So things like heart attacks and stroke can fall into that category. The bony pain that is experienced is a very nice example of that ischemia, that problem when those blood cells get stuck, blocking blood flow and causing damage beyond. That can cause transient pain, so like a pain crisis. It can cause bone marrow necrosis. Necrosis means death, where you have the factory, the bone marrow that makes your blood cells deep inside the long bones will have a spot that doesn't get enough blood until it actually dies. That is exquisitely painful. Avascular necrosis. So avascular means lack of blood flow and necrosis means death. So that's a problem that happens in ball and socket joints, like your shoulders or your hips, because the blood flow to that ball goes through a very small passageway, and that passageway is so key to getting blood to the end of the ball that when you have something like sickle cell, over time, that passageway can become narrowed or blocked. And that can cause the head of the ball and socket joint to collapse, which you can see in this irregularly shaped avascular necrosis hip joint over here. So these are two ways that we can see that blood flow interruption leading to organ dysfunction, and sometimes very severe outcomes from that. So those are just two examples of that lack of blood flow problem and two complications. We call that, as a category, vaso-occlusion. Vaso meaning blood vessels, and occlusion meaning blockage. This slide lists a whole host of other problems, complications that are due to that vaso-occlusion, that block of blood flow, including lung injury, which can include acute chest syndrome, but also some of the reactive airways or low oxygen that sometimes happens when the blood is not flowing easily through the lungs. Retinopathy, the retina is the part of the eye that sees. And those blood vessels at the back of the eye are very small, and they're very susceptible to blood flow being blocked, causing loss of vision or floaters in vision, which is why many of our docs will ask about that. Your spleen often doesn't function if you have sickle cell beyond the age of about 10. The spleen is an organ that helps filter our blood. It's basically a whole bag of very small, twisty blood vessels that makes the blood do gymnastics through it. And if your blood cells are getting to the end of their life, they get a bit stiff and they don't pass through those tight passages very well. And that's how our body knows to clear up old blood. In sickle cell, those blood cells are not always as flexible to start with. And if you have stress, low oxygen, a bit of a narrow pathway, those blood cells can change shape and get stuck. The spleen also has important immune system function to help us fight certain bacteria that are covered in a cell wall. So Haemophilus influenza, which is a bacteria, as well as certain types of pneumonia and certain types of meningitis. Oftentimes in sickle cell, particularly SS sickle cell, the more typically severe sickle cell, the spleen gets completely blocked from flowing blood by the age of about 10 years. Other vaso-occlusion or blood vessel flow interruption complications include priapism, which is a prolonged erection because the blood is not able to come out of the organ, and that can cause damage and issues with function that can last a lifetime if not dealt with. The kidneys are full of blood vessels, including a little knot of blood vessels called a glomerulus. And that's the part of the kidney that actually filters our blood. That's, again, a small bag of very tight blood vessels. So when your blood is thick, when your blood is pointy, it doesn't flow through well. And we can get sequestration. Sequestration means getting stuck in or sort of being put into a corner. And so that can happen in the liver or the spleen, causing the organ to swell up and get quite painful. And that blood gets stuck in there. So you don't have as much blood circulating your body and your hemoglobin drops. You get anemic acutely. So those are some of the complications from just the sickle cells getting stuck in places they shouldn't. Stroke, we're going to talk about later. So hemolysis, or blood breakdown, is the other main pathway of damage in sickle cell disease. When our blood bursts, when it is turning over, when we have blood cells not living as long as they should and not being cleared from circulation as planned from the spleen, it releases the hemoglobin into the blood system, which is quite irritating to the body and can cause inflammation of blood vessels. The byproducts end up forming stones in our gallbladder, which helps hold digestive enzymes. And it can lead to these particular complications. So pulmonary hypertension or high blood pressure in the lungs makes it hard to get blood flowing forward through the lungs and back to the heart to go around the body full of oxygen. Typically, that's related to high blood turnover, low hemoglobin, and it tends to be more common as people get older. The pigmented gallstones are different than the type of gallstones that are more common in people without sickle cell disease. So the pigmented gallstones are a bit harder to see on ultrasound and imaging, but they're made up of bilirubin, and bilirubin is a yellowish protein that makes people's eyes yellow and their skin yellow. And it's a breakdown product of hemoglobin when you've released a lot of hemoglobin from blood cells turning over. The hemoglobin also releases iron into the body, and this inflammation interferes with how the body uses iron, which can lead to too much iron in the body. In addition, many people with sickle cell will receive transfusions or have blood given to them, which also contains iron. Iron can end up in tissues where it shouldn't be, in the liver, eventually causing cirrhosis and liver failure. It can get into the heart and make the heart stiff and not beat nicely and elastically like it's supposed to. People can have it deposit in the brain and the pituitary system of the brain, which is the hormone control center of the body that makes things like our thyroid hormones that drive our metabolism, and also controls our reproductive hormones like estrogen and testosterone from higher up. The pancreas is an organ in the belly that can also directly have iron put into it and cause it to not function well, and that causes diabetes. This inflammation can also lead to an increase in blood clots, generally on the venous side of the blood system, the side of the blood that takes blood from the tissues back to the heart. So that can make a swollen, red, hot, angry leg if you have a blood in the deep blood veins of the leg. Or it can start in the lungs or travel from the leg to the lungs. And a blood clot in the lungs makes it hard to breathe. It's often a sharp pain that makes it, when you take a deep breath, it feels like you're being stabbed. It might make you faint when you stand up, and it might make you cough up blood. None of those things are normal, and those are emergency symptoms that need to get checked out that day. Single swollen red hot leg, sudden trouble breathing, sharp pain when you take a deep breath, coughing up blood or fainting, not normal. Get checked out. One of the big things we wanted to talk today was about the brain. So I'm going to talk a little bit about stroke and then jump into screening and some treatment options. So strokes are more common in sickle cell disease, including in young people. Strokes can be ischemic, so from blood flow not happening, or they can be hemorrhagic and bleeding. And a couple of the different ways this can happen is listed here. So ischemic strokes, or strokes because of a lack of blood flow, having a lower hemoglobin makes you more dependent on every bit of blood flowing through your body. You need to circle more blood faster to keep those tissues full of oxygen if each individual sort of volume of blood has less hemoglobin. Because of this, people are very dependent on having that good flow and have less ability to respond if someone has a lower blood pressure or somebody has a narrowing of a blood vessel because of inflammation or because of one of these sickle cells getting stuck and sort of blocking that nice flow. So ischemic strokes can happen from narrowing, from blood getting stuck from the sickle cells, from changes in blood pressure if someone has a quick drop of blood because they're bleeding or they have that sequestration, that blood getting stuck in an organ problem. Moyamoya syndrome is a particular pattern of imaging abnormalities that I have a slide on coming up next. And it's basically narrowing of certain blood vessels, and it has this puff of smoke I'll show you in a minute. But Moyamoya syndrome is an irregularity in the actual blood vessels of the brain that make people at higher risk of stroke, which can be ischemic or hemorrhagic, but often hemorrhagic. Hemorrhagic or bleeding strokes are often a complication of blood vessel abnormalities, and there's a higher number of aneurysms, little outpouchings of blood vessels in people with sickle cell disease. This is all sounding kind of intense and kind of terrifying, I think. This little red patch here is a puff of smoke. So moya literally means puff of smoke in Japanese. I can talk. And you can see how there's sort of an irregularity or a blockage of the blood vessel at the bottom of this inset picture, leading to sort of a tree of life of small blood vessels and that puff of sort of outside of a blood vessel blood at the top. So moya needs a scan to find it, but it is something that we take very seriously if we find. So that's my bit about complications. What is better than having complications is preventing complications. So what we try to do at all of our sickle cell clinics, because we have several across Ontario where we provide specialized sickle cell type care, is to look for problems before they're problems. And if we find them early before people get sick. So that's what we try to do. Sometimes even doing everything perfectly isn't as much as we like it to be. Some of the screening that we do regularly in children is a transcranial Doppler, specifically to screen for stroke. And I have a slide on that one as well. It uses an ultrasound to look at the blood vessel flow, sort of at the temples. If that's high, there's a higher risk of stroke. We do blood work to understand people's hemoglobin levels, to look for organ damage of the kidney and the livers, check for hormones, check the metabolism with the thyroid function tests. We do urine tests because sometimes your kidney blood test looks fine, that creatinine looks fine, but people will have protein in their urine or some other subtle sign of kidney issues. So urine tests are helpful that way. We use echocardiograms, which are ultrasounds of the heart that look at how the heart is moving and how the heart is beating. We might do pulmonary function tests or lung function tests where they sit you in a glass type of a box and they make you breathe through a small tube to look at how much air are you moving, how fast can you move it, are you emptying all of your lungs, which can help us screen for different types of sickle cell complications in the lungs. Sometimes it looks like asthma and is treated like asthma. But sometimes people have problems with transferring oxygen from the airways to the blood that need sort of different types of treatments. We do routine eye screening to check out the retina at the back of the eye and make sure that's flowing well, the blood, which might include fancy imaging or sometimes dye tests to light up the blood vessels in the back of the eyes. And we use MRI scans to look at the blood vessels in the brain, but also to look at iron in organs if we see signs of the blood tests of iron climbing up or in people who need a lot of transfusions. Here's your transcranial Doppler picture. You can see a child's head. It's not as easy to do in adults because our bones are thicker and it interferes with the ability of that ultrasound to get a nice image. And it shows that ultrasound probe in blue looking at the blood vessels in the skull, particularly the bigger blood vessels. And we're looking to see if as they narrow, the velocity, the speed at which the blood is going through is higher. And a higher blood flow means a narrower vessel, means a higher risk of stroke. If we see that, we're going to act on that. These are a couple of other preventative type treatments that we like to talk about. Now, I'm an adult doctor, so I don't give people penicillin because the evidence when we studied in adults is less there. But we give penicillin, or we recommend penicillin daily for children because the spleen is important in fighting infections. And there's a higher risk of an infection going from not very serious to very serious with some bacteria. And penicillin helps prevent that, helps prevent sepsis or blood poisoning due to infections. We always talk about immunizations, particularly for things that the spleen helps fight, like that Haemophilus influenza B or Hib. Pneumonia, so like your pneumovax vaccine type things, and meningitis are the ones particularly with the spleen we pay attention to. But anything to help that immune system help fight infections is something worth talking about. We like to make sure people have good building blocks of blood, so we often recommend folic acid, though it's quite well supplemented in diet for many people. And we look for other building block deficiencies like iron or B12. If you're iron deficient, more iron is better. But remember that blood turnover can sometimes lead to high iron. So iron is something we should check before people take lots of it, because we don't want you to get into trouble. We want you to be supplementing things to help, not doing things that might cause troubles down the line. And the other prevention thing is treatments like disease modifying therapy, or treatments that can help reduce the activity or the severity of sickle cell disease. I think everyone has heard of hydroxyurea. Hydroxyurea is our oral treatment, disease modifying therapy. It works in many ways. The most commonly identified reason is that it increases fetal hemoglobin, or the hemoglobin that we make as babies, because that does not use that sickle hemoglobin gene. It uses a different gene. So it will increase total hemoglobin. It increases the hemoglobin in the blood cell that is not capable of contributing to that sickling, that chain of hemoglobin that changes the shape of the blood cells. And it can help, because of that, reduce the early clearance or that hemolysis of those blood cells. So you have better hemoglobin, you have less blood turnover, and less change of shape of your blood cells. Has a couple of other mechanisms that help it work, but that's the main one: increased fetal or hemoglobin F. With those things, most people, but not all people, have decreased pain crises, decreased trips to hospital, less stroke, less acute chest syndrome, which is a life-threatening lung damage problem. And over a long time, this is a treatment that has less mortality, less death from sickle cell disease. It keeps people alive longer. It took us many years to collect enough data to show that. But it is a daily treatment that can help people. The risks are individual, and certain types of sickle cell are more benefited by hydroxyurea than others. So the mortality reduction and the reduction in death in these benefits I've talked about most study in SS hemoglobin and S beta thalassemia that does not make any hemoglobin A types, really severe sickle cell. Hydroxyurea was developed as a chemotherapy, and we're always trying to find maximal tolerated dose. So that's the dose at which we get the most hemoglobin F before I start making your blood counts go down too low. So bone marrow suppression, or suppression of the factory that makes your blood cells and blood cells getting too low, is a complication of too much drug. So we try to find that peak, the most benefit, before we get side effects. Call that maximal tolerated dose. Many people notice their nails change color, get quite a bit darker. Some people notice brittle hair. On the handouts, because this is still used in a number of cancer conditions, it does say that hydroxyurea is associated with an increased risk of cancer, which has never been shown in sickle cell patients, but has been shown in other patients who are using this as a treatment for cancer. But that's a really important thing to talk about and be comfortable knowing your risks and what they look like with your healthcare provider. Leg ulcers are another thing that we tend to see in our cancer population, and is trickier in sickle cell disease because sickle cell disease itself can cause leg ulcers, and sometimes hydroxyurea can help treat them. But sometimes hydroxyurea can be associated with poor wound healing and cause problems. So again, a very good discussion with a doctor you trust is recommended. I'm almost done, guys. Other disease-modifying treatments are listed here. Transfusions, I have a bit more on the next slide. So our disease-modifying therapies, hydroxyurea and transfusions. Treatment with curative intent is our stem cell transplants, mostly with sibling donors, but lots of research happening there. We're waiting to see the final says on gene therapy, but it's looking like Canada maybe is going to approve this, but still waiting on the final words. Voxelotor or Oxbryta got pulled from the market due to when they did enough research and had a big enough population of people, there were negative side effects that made that unacceptable for continued treatment. So Voxelotor is off the market, not that it was easy to get in the first place in Canada. Treatments of complications also depend on what organ is involved and often brings in specialists to help us manage that. So that avascular necrosis, that ball and socket collapsing because of lack of blood flow, might need injections into a joint or even joint replacement. For something like moya in the brain, because of a narrowing, sometimes they can put through a stent and pop open a blood vessel and help keep the blood flow more open and more free and help prevent strokes that way. So there's sickle cell treatments that we use with organ-specific treatments, and that's why many people end up with many specialists. We give transfusions to try to basically replace anemia. So if people are anemic, they have low hemoglobin, we try to top that up. And we top that up with hemoglobin A, which is hemoglobin that people without sickle cell generally have and does not have that change of shape of the blood cells from it. Sometimes we do exchange transfusions where we take out the blood in somebody's body, that hemoglobin S, as we're replacing it with new blood with hemoglobin A to help make sure there's not enough hemoglobin S and those sickled shaped cells to get stuck in organs like the lung or from stroke. Blood comes from other people, so it can come with the risk of antibodies and bloodborne infections. And every bag of blood has iron. So we have to watch for iron overload in people who are getting transfusions regularly. This is really the end of me. The best treatment for stroke. Stroke is a particularly scary, potentially devastating, and very serious complication of sickle cell disease. So it's something we look for, something we actively try to prevent. And when it happens, we try to be very aggressive at preventing another stroke, because a stroke can be a small temporary sort of a thing or a life-changing event that can lead to serious trouble, maybe moving half of your body, how you're thinking, how you're seeing. So we try to be very on guard for stroke. There's a couple of trials listed here because any doctor just has to throw out some research for you. So chronic transfusions, so people getting blood once a month or so, is the best therapy for stroke prevention in children who have abnormal transcranial Dopplers, TCDs, that high velocity flow showing narrowing. If we want to stop them from getting to stroke, at least a year of transfusions is suggested. We know that if you've had a stroke, the best thing is to continue transfusions. And we know that if your TCD, if your transcranial Doppler is abnormal and you have changes on your brain, so vasculopathy or abnormal blood vessels, that stopping transfusions is a higher risk of stroke. Hydroxyurea wasn't enough in people who had those changes in the blood vessels in the brain. If it's moderate to severe, hydroxyurea is good, but it's not enough. Transfusions are better. But we know that if you catch it earlier, that hydroxyurea is good at preventing stroke and is good at preventing the transcranial Doppler number from getting worse, and therefore preventing increased risk of stroke. So hydroxyurea, good at prevention, but once you're into trouble territory, you need more, and that's transfusions in a perfect world. But we don't live in a perfect world always. And so really the important thing is it's great when the evidence says do this, but the evidence comes from a population and not from the person in front of me in clinic or in the hospital. And I think it's really important that we, listen to the stories of the people that we're working with and that we talk about the risks and the benefits for the individual. And that we really work together as a team to find the best therapy, the best treatment, the best plan for that individual with the resources that we have. And that we look at doing this in a multidisciplinary way. So we look at treating people's physical health with perhaps hydroxyurea, but also are addressing other factors of life like emotional health, mental health. Can you work? Can you function? Do you have access to food and safe housing? Like all of this comes together. And it's really important that we're looking at that personal context to find the best way. So that's it for me. Thank you very much.
Sarah, wow, no, that was fantastic. Not only was just the chamber of your delivery was so soothing, but I gained so much from that comprehensive talk. I think it was a great opening and a great orientation for folks on the line before passing the microphone now over to Miss Marlene Scott. So Marlene, as we mentioned, and I'm seeing the glowing comments are pouring in the chat, Sarah. So I hope you have a chance to look at that. But Marlene, as we mentioned earlier, please do take your time setting the stage for not only your lived experience, but some of the pearls of wisdom that you can go on to deliver the folks who are here waiting with bated breath to hear from you. So without further ado, I'm going to pass it over to you, Marlene.
Thank you.
Thank you.
Good morning, everyone. As mentioned, my name is Marlene Daly Scott, really. And it's not your fault. In Jamaica, and I believe I may have some Jamaican persons online, not sure. They expressed an interest. I'm known as Marlene Daly Scott in Jamaica, when I got my papers to migrate to Canada, for some reason, they apparently did not like the name Daly, so they just gave me Marlene Scott. I was not amused, obviously, since I wanted to keep my father's name, but suffice it to say, in Canada, I'm Marlene Scott. So as was mentioned, I migrated in 2013, migrated to Canada in 2013, mid-2013 to be exact, and came straight to London. Fortunately for me, I got a job within 6 weeks of being here. I was actually at a newcomers workshop, and so I've been at Western. As was mentioned earlier, we're both Western supporters, Mr. Hines. I've been at Western, I like to say, for as long as I've been in Canada. And I've been in London, obviously. I was doing pretty well when I was migrating. Many persons in Jamaica were very concerned about my coming to Canada because of the weather more than anything else. And I believe I was doing pretty good until about 2017, early 2017, when I fell ill and I had to go to the university hospital simply because it was next door to where I work. I was actually at work when I went. As a result of that, I remember when I went to the university, they were there just doing some tests and nobody seemed to be able to pick up anything. So I mentioned that I'm a sickler. For some reason, persons were still looking strange what is sickle? I'm like, I have sickle cell disease and I often trouble with acute chest syndrome. So I'm mentioning those things, hoping that, people will be prompted. And then, forgive me for saying this, but there was an African Caribbean person, a dark nurse at the hospital, and apparently something clicked. I believe, I'm not sure if she's from the Caribbean or her parents, but then she recalled hearing about sickle cell disease. That's as close as it got at the time. When I mentioned it, and she's like, oh yes, I've heard of sickle cell disease. So they started from there. I spent about, I want to say 6 hours or more in the ER, but I was sent home that night. However, a couple weeks later, I started getting letters in the mail about appointments to go to Victoria Hospital, etc. And so I started my sojourn at Victoria Hospital. About 2019, I was referred to a neurologist at the University Hospital again, but still a patient of the Victoria Hospital, where is the clinic that I see my hematologist. So I started seeing this neurologist, and I believe he may have saw some things, or they may have seen some things based on blood work. And so at the end of the day, I saw him and I was sent to do MRI about early 2021. I was told in 2021 that there were signs or scar tissues of stroke. I was asked if I ever had stroke. And I said no, not that I was aware of, but I was told that based on the MRI results, there were scar tissues. And so even to this day, I still say occurrences of stroke, because in my mind, stroke is something that you know for a fact that you have it, right? You can't move, your speech is blurred, and lots of things. And I'm like, but I don't recall any of those. So I think I'm still trying to convince myself that I may have had stroke, occurrences a couple of times that I was not aware of. I even went as far as to ask the doctor, are you referring to TIA? In first aid, they mentioned here. And I'm saying, oh, it must be something like that. But he's like, no. I'm like, okay, if the doctor says so, So I started seeing the neurologist there. Over time, however, I've been referred to several specialists. But before I go to them, I may have jumped the gun in saying my first discovery of sickle cell was actually in high school. And that's weird because I was a netballer at the time. I like to say very good, very active, because for those persons who know the game of netball, I was the person who played center. So you know you have to be active for center because you're all over the field, all over the netball court, whatever. And I remember after an exhibition game, I was okay, but the next day I went to school, I could not move, like I was in pain. I spent the entire day just being in the sick bay, couldn't do anything, couldn't walk, couldn't anything. And so it was then that they started doing all kinds of tests. And then the next thing the doctor was telling me, all right, you need to quit netball, that kind of thing. Started going to the hospital now, moved from the private doctor to the hospital. And for 3 months straight, I was going to the hospital doing several blood tests. They would not tell me anything except that something is wrong with your blood. I'm still not sure why that phrase, right? If there's a name for it. But you ask no question. Like I said, for about 3 months, I went to the hospital. I heard nothing definitive. Still being sick all the time, I went back to a private doctor and he looked at me, one look, and he said to me, have you ever been tested for sickle cell? I said, no. That time I was obviously a teenager. And he said, you look like you have sickle cell. I'm going to send you to do a test, and the rest is history. So I was a patient for years at the sickle cell unit in Jamaica. Migrated. Up to the time of migration, I told them that I was migrating. I did everything. I kind of got it clear. I got a report so I could take to Canada, but like I said, I held it for a couple of years because I was here about almost 4 years before falling ill. But I did do a final checkup because I wanted to make sure I was okay coming to Canada. The doctor, had some suggestions in terms of how I should dress, etc., and what are some of the things that would help me because she studied in Canada. So she was saying, if you do this, do that, you should be fine. So here we are now in Canada. And one of the things in Jamaica that I experienced before coming to Canada, yes, acute chest syndrome was almost always the case that would send me to the hospital, right? But I also had problems with meningitis. And I was hospitalized with meningitis for 2 weeks. So I heard Dr. Sarah talking about all those things. And I just thought I would put those in, right? Meningitis for sure, acute chest syndrome for sure. I've had problems with my vision. Started in Jamaica. I used to see the ophthalmologist at a university hospital there too. And then I came to Canada and I started seeing an ophthalmologist as well. So now I'm in Canada. Now I'm seeing an hematologist. Now I'm seeing a neurologist. And as time went on, I was also seeing an ophthalmologist. Like I said, I've had situations where twice, 2 separate years, but consecutive, I've had to have work done on my retina. And those of us, who are sicklers or who have studied the disease would know that that is a problem too, So ophthalmologists, neurologists, hematologists. Then I started seeing an osteoporosis specialist because the next thing you know, I'm having problems, and then I'm now told that I am borderline, suffering from osteoporosis. So I believe next year is when they say they're going to start treating me because I was 0.5 off what would be considered full-blown osteoporosis. So they were like, okay, it's time. But of course, I'm on the calcium carbonate and the, what is it, B3 or D3 or something like that. So yes. In addition to those, I'm also seeing a nephrologist because then I started having problems with my kidney, protein in the urine. And again, Dr. Sarah spoke about that. And so I'm seeing all these persons and I'm constantly having to take time off from work, for one appointment or another. So I'm getting into the mental health aspect of it because it does take a toll when you have to there are times when I would submit forms for like 3 or 4 upcoming appointments. And as soon as I hand over the form, I reach home and in my mailbox is another letter from the hospital, you know, saying, you need to go do this test, you need to see this doctor. I've had situations where I've worn a cardiostat for 2 weeks. I've had the same echo test done, the pulmonary function test. I've done them all. And so I smiled when Dr. Patterson was, you know, talking about it because I'm like, yes, check. And I'm just checking off the list. So we continue. So now I started seeing the kidney specialist, the nephrologist, and then I'm on kidney meds because they're monitoring now my kidney and the protein. And I must, you know, say a big thank you, a big shout out to Dr. Saul before I go any further, because once Dr. Saul finds it, he's making sure that I'm seeing all these specialists, right? Which is why I have them all. And my waiting period, strangely, is call it 0. If I see one today and I need to do an MRI by next week, I'm getting my appointment. So much so that last time I got an appointment and I'm like, can you change that? And they changed it to a couple of days later. But then my supervisor said to me, did you know that the waiting list sometimes for MRI is like as long as 6 months? I'm like, what? I'm like, okay, guys, anytime I have an MRI to do again, please remind me to keep the date because I can't be changing appointments when there are other persons waiting so long to be seen, right? It's not cool. So, but I'm just saying this to say that these doctors are excellent, you know, and I really do appreciate them. So yeah, I'm seeing the kidney specialist now. And about February of this year, a situation happened where let me just go back to 2021, which was when I did an MRI and the neurologist mentioned that there were some scar tissues, but what we did not know was when did these occur? Did they occur before I migrated? Did they occur after I came to Canada? He said he could not tell. What he could tell that I did have stroke and there were scar tissues. So what he did, he suggested doing a follow-up in 6 months after they changed my medication because again, some things were happening and Dr. Patterson again spoke about, you know, just trying to get a tolerated dosage, right? And I was having problems with dosage. They changed it here, they changed it there. They went back to that one because they were just trying to find that tolerated dosage. But before I get to that change, so he said, okay, what we'll do 6 months later, we'll send you to do another MRI to see, you know, if anything changed. Because that would tell him now, if based on the dosage, you know, there was improvement, there was a new occurrence, whatever. So that was that. We did a new MRI 6 months later, which I think took me into January 2022. I remember because I traveled that December. And as I came back, it was time to do my MRI. He said, well, there were no new scars or so. So clearly whatever happened, you know, is as when we did the MRI in June of that year, said, okay, fine. Now about the dosage. I've had hydroxyurea change. I think initially I started out with 1 every day. That clearly was not working to their satisfaction. It was changed to 2 tablets per day, Mondays to Friday, and then 1 Saturday and Sunday. So that was what, a total of 12? Yeah, so a total of 12 tablets per week. For some reason, I don't know, based on blood work, they still were not satisfied. So they changed it to 2 every day, 14 tablets per week. But then I believe, and that was around when in the same December, because like I said, I traveled, so I remembered, and I was so sick, like I was leaving the Monday and I had to rush and do blood work the Friday because I think the week before, the doctor was not satisfied. So he took me off it and he said, okay, do a blood work just before you travel so I can have that information. And I remember he called me the evening to say, stop, totally stop taking. This is when I was on 14 tablets for the week now, 2 every day. He said, for the next 2 weeks while you're in Jamaica, do not take any medication because I could barely breathe. The shortest walk and you can't speak to me. Or if you speak to me, I can't answer you because I could not catch my breath. I don't know what was happening. But clearly he had an idea. So he was like, he told me months later that it was their fault, of course. But apparently, again, based on the dosage, something was wrong. So he was like, do not take it, rest for 2 weeks, and then we start you over. When we start you over, go back to the dosage of 2 each day, Mondays to Friday, and 1 on Saturday and Sunday. So that is what I'm stuck with right now. So we're talking about everything. We're throwing everything into the mix. We're talking about dosage. We're talking about everything. So here I am now. In February of this year, I was supposed to be getting up to go to work, and I remember waking up in the very early hours of the morning. I think it could have been about 2 something for a washroom break, and I could not get up out of bed. And I'm like, wow. So I lay there for about 10 minutes just trying to get up out of my bed, and I could not get up. And I'm like, what is happening? But it came to me immediately. I'm like, am I having a stroke or something? And I'm there and I'm trying to figure this thing out because I live alone. And I'm trying to figure this thing out. And I started using, I believe it was on my right side. And I'll tell you why I use the word believe, but at the time, my recollection, it was on my right side because I had to use my left hand to kind of lift my right hand. But not only that, I started thinking, but I'm supposed to go to work. How am I going to drive? I'm right-handed. And I started thinking about work even before thinking about my health, right? So that's how I remember that it was my right side. I'm right-handed. And here I am now, not having much function on my right side. Anyway, like I said, I use my right and my left hand to lift my right hand arm, and I kind of rolled myself off the bed because I needed to use the washroom, and I'm holding on and I'm going to the washroom. I went into the washroom and I remembered looking at the mirror and I'm making facial expression. I'm like, I'm doing all kind of things with my, because I'm saying if I have a stroke, then my face, they're affected or impacted somewhat, but my face is normal. So I use the washroom. I somehow made my way back to bed, and I went back. I fell asleep. I was feeling a little better, so of course I dragged myself to work. I recall saying to my supervisor, though, that I had a problem getting up this morning. I could not get up, and I was saying to her what was happening to me. So about 2 weeks later in March, it was time for me to see the neurologist. And of course, they want to know anything has changed since the last time we were there talking. And then that came back to me, and I'm like, oh, and I was recalling now what happened to me. And he had this expression, and he did not say anything to me. Or did he? No, I think I said to him, I started wondering if I was having a stroke. So I was telling him all that I did. And after I was finished, he said, all right, so for most parts, you did everything correctly. What he said, if that were to happen again, instead of just trying to lift your hand, try to lift your leg as well, because it would be the entire body. He said, instead of trying to make facial expression, speak out. Talk to yourself, because if there's a distortion in the voice, you will hear it, or you'll know if you can even get anything out. The next thing he said, if that happened, do not go back to sleep. Do not go back to sleep. And I'm smiling because I'm thinking that's all you're saying. You could die in your sleep. Of course, he did not say that. He's like, do not go back to sleep. Call the ambulance, right? So I'm listening and I'm doing all of that. And I'm listening and I'm note to self. But then he said, I'm going to send you to do an MRI. So I had to do an MRI again. And a couple of weeks later, it was not the neurologist who called me first. It was the hematologist. Dr. Saul called me and asked me to come in. So I went in and he said to me, this is what happened. And Dr. Call will speak to you more in detail. That's a neurologist. But I think he wanted now to discuss transfusion, blood transfusion as an option, because the hydroxyurea is not enough. There is no need for another treatment or supplemental treatment. So out of that MRI and that situation, I saw the hematologist. He called me first. The next person to call me was the nephrologist, the kidney specialist. She called me too, right? And she mentioned what was going to be happening. So, and then I saw the neurologist and he spoke to me. Suffice it to say, they were all on the same page. I now needed to do blood transfusion, and we're gonna have to, how did I feel about it? What were the pros? What were the cons? Etc. So we discussed that. Around about that time, I also had a problem with my blood pressure. My blood pressure was so high. I was looking at 150 odd over 100 kind of thing. And it was so, and I remembered the neurologist. I was on kidney meds, like I think I was about 2.5 mg, let's just say, per day. And I'd gone to see the kidney doctor, so she had changed it to 5 mg. So she doubled the dosage. But I was having all these appointments around about the same time, like weeks apart. So the next thing you know, when I saw the neurologist, it was still so high that he did it 3 times within less than half an hour. And he was very concerned and he literally doubled it. So I was now within like a month, 2 months period, I moved from 2.5 mg to 10 mg, right? Just trying to get this thing under control. And 10 mg is where I am right now still. And like I said, having spoken to all 3 of them, the final step was to go ahead with transfusion. Because my thing is, you're the doctors, you're the specialists. I can't help myself for sure. So if you believe that this is the way to go, I'm going to trust you. You have been taking care of me, quote unquote, for all this while. Why not continue, right? I would just take your word for it. I was gamed, even if I was a little scared, I was gamed. And so we decided to go ahead. So the nephrologist, the kidney department, they were the one who actually took me over to having had that talk with me now to, it's called apheresis, which is where they're going to be doing the blood transfusion. Of course, when I went there, my veins, and I've always known this, that my veins are not the best. You can barely find a vein for blood work. So when they mentioned that they're going to be needing veins and strong veins and probably in both ends for the blood transfusion, I was hopeful, but I knew it wasn't going to happen. So then I was told that they'll now have to do a surgery to insert a double port. I had no idea what that was. I would have done anything else but surgery. I did not want to do another surgery in my life, but again, it was out of my control. I had to do it. So an appointment, I was there sitting waiting, an appointment was made. I got a letter from the hospital, and we have several hospitals, like everywhere else. But what I find interesting too is like, I may get a letter saying, go to the University Hospital, or I might get a letter saying, go to the Victoria Hospital. I might get a letter saying, go to the St. Joseph Hospital. And I'm like, so they're always sending me somewhere else. So St. Joseph Hospital now was where I had to do the surgery for the port. They decided that they had to insert a double port. I think I was told this by apheresis though, that they would have to do a double port. So for a double port, for those who don't know, the port is usually, well, mine is inserted above, my breast on the right side. The insertion is about 4 centimeters long, 2 centimeters wide, and it's under the skin. It's placed under the skin. It was a local anesthetic, so I was very much aware of everything that was happening. I believe it was well done, in as much as I was scared leading up to, prayed a lot, really, really scared. It was like nothing. And I was so thankful for that. Because like I said, if I have my choice, I don't ever want to do another surgery, right? But that one, it was nothing. And it was good. So I did that. It took me a little while to recover. And I think I did a surgery the 23rd of May to be exact. That was a Thursday. I was off work Friday. Yeah, the weekend, Saturday, Sunday. I was off Monday and I went back to work the Tuesday. But I wasn't doing anything heavy. Needless to say, by the 12th of June, so 23rd May, I'm now at the 12th of June. 12th of June, I was getting up to go to work again, another early morning, and I started feeling sick. Immediately, I recall what the doctor said to me about next time you feel sick, even though I didn't feel like I was having a stroke, but this time I'm like, you know what? I'm still going to call the ambulance. I called the ambulance. I didn't call my son. I knew I wasn't to drive myself. I called the ambulance. The ambulance came in the early morning. It was about 6 something in the morning. And I went to the hospital. 12th of June. I was admitted. At the end of the day, I was admitted for 5 days. 5 days, 4 nights. They found that I had blood clots. My lungs, they found in 2 sections, my lungs and my spleen. But I must pause here to say I have something that is called PFO, which is a heart defect. And what happens is that, there are flaps. And apparently, sometimes the clots, as I understand, and Dr. Patterson can always explain or clear for me, so the clot, I don't know how it happened, but some clot at the lungs and it went down and it broke up and it ended up in the spleen as well, because it can travel, right? So something happened there and I was being treated for that in the hospital. At the time I was admitted on the 12th of June, I had an appointment to my first transfusion on the 18th of June. On the 18th of June. So here was a transfusion coming up, but then I got sick and I had to be admitted to the hospital. What I also had pending was a situation where I was supposed to be a part of a study surrounding, I believe, blood clots as well, because they were mindful of the fact that once a foreign object is placed in your body, it could result in blood clots. So I had met with a group doing a study and they were just waiting on me to have the port inserted before we started the study. Let me just quickly add that was off. The moment I had blood clots, that was off, because the whole idea was to be preventative and not curative. So once that happened, that was through the window. So here I'm in hospital now. But the decision was taken to discharge me on the 16th, which would have been the Sunday, because my appointment for the transfusion was scheduled for the Tuesday. And what they explained is that if I stayed in the hospital, then the transfusion would be off. So since I was there for a couple days and I was feeling somewhat better, why not, go home and rest? They did all the blood work there for the transfusion, just so that I could stay home and rest the day before, which is usually when they want to do the blood work for the transfusion, so that I could turn up on the Tuesday to do the blood transfusion. So I actually still had bandage on and stuff when it was time for the transfusion. So transfusion really is, friends, as a result of this development where the stroke is concerned, the frequent or the occurrences of stroke, because what I was told is that the next one could be fatal. They're trying to prevent it. So, let's address it here and now. So I'm now on monthly transfusion. And each transfusion, in terms of the effect or the side effect, has been different. It's never the same. I've had a couple and it's never the same. I've had instances where I swear they would have had to readmit me as soon as the transfusion was finished, because I'm feeling that ill. I'm nauseous. I'm fainting. I want to vomit. I'm having serious bowel movement. I've had instances where I'm having a slight reaction in terms of a swelling. The last time I did my transfusion, in the middle, that was the only time, the first time in the middle. I think I've gone 5 to date, started in June, and I've had one every month since. The last time in October, I recall they had to kind of slow it down, because during the transfusion, I started developing some reactions. I was vomiting, my blood pressure fell, and so she had to be monitoring me, giving me extra fluid, giving me, was it calcium? I think it was calcium and stuff. So I find, but I'm thankful that this time I was actually still on the bed doing the transfusion when it happened, because there was a time before that I almost fainted 3 times after getting home, that I had to just try to find the futon to lie on because I couldn't make it back to the bedroom. So, but what they ask is that each time I do the treatment, I let them know how I feel the next time I see them, right? So I've had instances where I've gotten extra amount of IV fluids. I've been asked to just remain in my position for longer. I've been asked to walk around in the hospital where they're walking close behind me, monitoring me. How do I feel, etc. So, so that has been an experience. But I also want to say the last time I did transfusion, I had 8 pints of blood. And I'm like, 8 pints? Again, I don't know what that means. I try to ask questions, but sometimes you don't want to seem too nosy. I know we should feel comfortably enough to ask questions about our treatments, but sometimes I'm just like, I can't bother, whatever. But yeah, but I did ask some questions because I'm like, am I seeing correctly? I'm counting the bags, or the packets on the bed. And I'm like, so I started asking her, and I'm like, 8? And she's like, yes, we ramped up your treatment. So I'm going to see. My next one is on the 9th of November. I guess I'll see if they continue to give me 8 pints or. So I said to her, I did say to her, so each bag is a pint? She said yes. So I said, we'll see, if it stays that amount, because I believe, I think I've seen 6 before. Yeah, and she did say that they have ramped it up. So I'm not sure why. I find that I am very comfortable with doctors. So what I tend to do is, all the questions I have, I wait until I see my hematologist. If I have 1 million questions, he's the one who's going to get all 1 million questions. I see him again in December. So I guess in December, I will really have a chat with him in terms of, are there any progress or is there any progress, you know, where next? Because I need to know. I remember as a result of the blood clots, when I went to see the hematologist, Dr. Sol, in, was it August? It could have been August, I don't remember. Somebody said, you know, you need to see a doctor, and I don't remember that. I think his name is Lazana or something. I'm like, no, I'm not aware of that. Only to find out that that person is also an hematologist who specializes in blood clots. So I'm seeing yet another specialist. Another hematologist, but this one specializes in blood clots. And I was told that they're not going to be removing the port, because at first I was of the impression, well, based on the information I received from the hospital, talking about the insertion of the port, or you clean it, or you manage it. There was also something saying removal. So I'm like, okay, so this thing can be removed. But then I was told when I went to the hospital in August, September, that it's not going to be removed. When I saw him in September, it's not going to be removed. I'm like, okay, I guess I'm going to be wearing a port for the rest of my life. So I don't know if I'm to assume that I'm going to be getting blood transfusions for the rest of my life. But like I said, it's something that is a question that I'll probably have for Dr. Sol, or if not, Dr. Carr, the neurologist, later on, even a kidney specialist, because I'm by now I've been seeing those for a couple of years, right? So I'm comfortable talking. I'm comfortable talking to them. It's not like the others who I just started seeing as a result of blood transfusion and the blood clots. So so that is it. But friends, I just want to say, you know, it has been a journey, because even though I have hemoglobin SC and it is considered a mild to moderate form, I find that I have been having a lot of these things, a lot of these symptoms. And sometimes I remember once, like, and I don't want to exaggerate, but I'm trying to recall, I believe once I would have probably had about 8 appointments in like a 2-month period. And at that time, I became so overwhelmed because I just could not deal with it. And I honestly don't think I was overwhelmed because of the treatments and the need for treatment, but I believe I was overwhelmed because I have to keep explaining to somebody else why I needed time off. And it just got to me, right? Other situations that I've had to deal with, sometimes I'm not able to work. Right now, I am what you call sessional. So because I work at the university, my peak periods are September to April, when the students are there, obviously. I tell them that I'm available for work May to August. So, but I don't necessarily get all the hours, right? And so what you find is that sometimes I'm out of work and I'm on EI. No medication. It is a struggle. We're going to the hospital can be a struggle in terms of parking, going and paying the parking fees, right? Luckily for me, with the blood transfusion, I'm not supposed to drive myself. So what happens is that I will drive to my son and I'll have him take me to the hospital, and I will let him know when I'm ready, and he will pick me up, right? And I do that because, again, it's me, it's my treatment. It's very frequent. And so I use my vehicle. I don't want him to use his vehicle, because let's face it, even though we have our challenges, you know, we are still mindful of others, right? And what they give up to take care of us and to assist us. And so I personally try my best to minimize the impact on others. So whereas I don't drive myself, so I don't have to worry about parking there, I still use my own vehicle to make sure that I'm transported to the hospital. My son and his wife, you know, it's now a situation where every month after transfusion, I have to stay by them for recovery because I don't know, how I'm going to be feeling within the next 24 to 48 hours. And so it's good to be around them. Sometimes I'm there from even the night before, But going back to some of the things that overwhelms me, sometimes financially, it's a challenge because of these additional expenses, because I am missing work, especially this past summer. I was missing work because of surgery, because of hospitalization, because of transfusion, right? So not getting paid and then having to buy medication. In some instances, additional medication because of increased dosages or a new medication, because I've had to take new medication for like heart. My heart rate was of such that not only did they increase the dosage of the blood pressure or the kidney med, I'm not even sure which one it is, but I've also had to take additional medication for that. I'm now on blood thinners because of the blood clot. So that's additional medication too, and so on and so forth. Now, in terms of what are some of the benefits that I've had, thanks to the Sickle Cell Group of Ontario, they have a fund where once per year we're allowed to pull down and, they will give us a grant, I've benefited from that twice. I believe it would have been in COVID and this year again, because I was really struggling with some funds and the amount of time that I was not working and medication, like I said. So, that one I know of. I don't know of others. I've had to also give up a part-time job that I'd started earlier last year, just to earn extra funds, to offset some of the expenses. This is in the care. So I was a care pro, and based on my health situation, I've had to give that up because I can't be taking care of somebody when I'm not well. And some of the patients are usually older adults. Like I've had patients who are 90 or year old. Sometimes they don't have the balance. They're coming on me. So I realized with that injury right here, because this area that I'm touching, guys, it doesn't get a chance to heal, quote unquote, properly, because they're in it every month. They're in it every month, flushing it. I'm getting 2 injections every month. It can be quite painful. They're inserting IV lines for the blood transfusion. It's actually an exchange again. Dr. Patterson mentioned that because they're trying to take out some of my blood and to, replace it with somebody else's. And so it is and then because now I am on blood thinners, I have a tendency to bleed. So sometimes the pressure that they have to put on it to ensure that I'm not bleeding at the end of the transfusion, right? And I've had instances where they have said to me, you just love to bleed, don't you? Because, so it can be a very painful experience. It's always sore. Sometimes I'm getting up and I have to literally hold it to get up so as not to feel the impact of it, while I'm getting up, because it hurts, because I can sometimes feel whatever is there, the port, not whatever, the port, I can actually feel it moving. I don't know if it moved. Again, Doc can tell me, but I feel like it moved because I feel it. I don't know. It's just weird, So friends, and I know I'm laughing, and I do laugh through it because it is what it is, right? And at the end of the day, I'm grateful, for the care, excellent care. I appreciate everyone involved, even those who just give moral support, which would be all of you guys online. I'm definitely grateful for Scargo, whatever it is pronounced. I'm grateful because we're on the chat and we read stuff and we learn stuff, and sometimes we jump on a webinar, and so, like I said, the fund for those persons who might be having financial difficulties, the social worker, my social worker is very supportive. Unfortunately, my last visit, we spoke about disability. I don't think I'm there yet. I'm nearer to, what you call it now? I'm nearer to retirement. I'm hoping I can hold on to retirement, yes, but friends, I just want to thank you for this opportunity. It is my prayer that, and my hope that whatever was shared today would have benefited you. I don't know. I just want you to take away that in light of my stroke experience, I don't know if it is always as active as some of us think it is. And so I believe we have to be careful, because had it not been for probably blood work, I believe that is what initiated it, and subsequently MRI, I don't know if it would have been that obvious. And here I am now, because like I said, after February of this year, and telling the neurologist what happened, and he did MRI and he confirmed that I was actually onto something. There were signs, right? So had it not been for all of those things leading up, I would not have known, right? And so just be vigilant, ensure that, you are getting care, you are keeping care. There was a time in Jamaica, I'm going back there because there was a time when I would miss my appointments at the sickle cell clinic. And I remember once I went and the doctor was like, "You did not come for your last appointment. What happened to you?" And I said, "I wasn't sick, so I didn't come." So, and the doctor was like, "Don't ever do that again. We need to monitor your blood. We need to do your blood work because something could be happening."
Right.
Right. And because I actually missed it. And then I went when I was feeling sick some months later. So friends, just be vigilant. Take care of your health. Do what you have to do. And if you're in doubt, talk to your doctor and ask your doctor to check it out for you, just to make sure that you can get appropriate care. I will end there, and I thank you guys for listening.
Man, Marlene, I mean, you didn't have to tell me you're Jamaican, because the way you masterfully walked us through that story is a testament to not only how fantastic you are as an individual, but in capital letters, thank you. That was a profound, really comprehensive walk through your journey. Thank you for sharing those pearls of wisdom. Thank you for being so vulnerable. And just thank you for once again highlighting, the great care you're under with Dr. So he's a longtime contributor to the Skego as well. Only heard great things about his care, and I know, and I can feel confident knowing that you're in his care, because I know he'll be giving you the best care that he possibly can receive. So thank you so much for your sharing your personal experience. I'm happy this Skego was able to offer some help and some support, even in a small way, and always know you can count on us in any other way. So friends, I want to make sure that folks on the line have a chance to ask some questions. There's a few questions in the chat. One person, Cecil, I know you had your hand raised, so we've now entered the Q&A portion of the conversation. So the first question, I believe, may go to both folks, as a matter of fact, but it was during your presentation, Sarah, where an individual said, "Thanks for this presentation. Does living in cold regions influence outcomes, especially in some very cold Canadian regions?"
So definitely cold is a trigger, and we see both the onset of cold weather, but also in Southern Ontario, we have cold to warm to wet to dry to cold to warm pressure changes, and that swing often does precipitate crisis. So we do see that as a trigger. Dressing warmly, staying warm, lots of gloves and hats and scarves and bundling up helps. But it is, sometimes even if you do everything perfect, you still get a crisis. So yes, it can trigger it. Dressing warmly helps. Sometimes it's not enough.
Thank you for that, Sarah. Marlene, don't get too comfortable off mute. There's a question for you. One person asked, well, they thank you for sharing your experience with transfusions, and they're wondering if you mentioned, you've had different reactions during different occurrences. Do you feel you've built some type of natural immunity, or, some natural kind of protection having gone through those experiences?
I'm not sure. Well, all right. So what I know is The only thing I've been told is to make sure that I drink lots of clear fluid, right? Before am I walking and stuff? That's just general exercise. But in terms of the reaction, I don't think, because I believe Dr. Patterson mentioned their antibodies. We're getting blood from other people, right? And so because I was even assured of this, that if something is wrong, you know, they're not going to force me to continue. Let's just say I'm getting blood from my son and it doesn't work. They're not going to be taking blood from my son all the time, right? They're going to change it to somebody else. That was my impression. So I'm saying this to say that I believe the reactions will change depending on several factors. I don't necessarily know what all those factors could be apart from the type of blood on that particular day. But like I said, the reactions have changed. There was once when I left the hospital and I felt transformed. I felt okay.
Wow.
Nothing, zero, zilch. But there were other times when there was another time when it was, I didn't even realize it was a reaction until afterwards. I just knew that I went home, I went to sleep. Always afterwards, I went to sleep. I woke up with a slight swelling on my lip, you know, like, you know, it felt a little heavy.
Yeah.
And I just come from Jamaica. I came from Jamaica because I did get permission to travel briefly in August because my mom and siblings were worried. And so both doctors, Saul and those at the apheresis unit, gave me permission to do a quick thing and to come back in time for my next transfusion, which I did. So I brought up some elixir type medicine from Jamaica. And I remember I had a presence of mind to take it. And when I take it, within a couple seconds, I was feeling better again. So I realized it was an allergic reaction. But then the next transfusion, I was there and the guy beside me, and oh my God, guys, let's continue to pray for each other. He was doing a transfusion, and it was the first time that I became traumatized on the table because this guy was crying so hard that it literally, I started crying. I wasn't crying alone, but I started crying. And I remember at one point I heard him said he was having an allergic reaction, and I heard him saying, we're gonna give you Benadryl. So I'm like, oh, so apparently that was what was happening to me, right? I was having an allergic reaction that I wasn't aware of, but that is why the thing cleared it up. So I remembered I mentioned it the next time and they said yes. So I'm saying this to say that it can be different. It can be a different reaction each time. That time it was just that and the elixir cleared it up. Another time I was okay. There were other times when I wanted to faint. I wanted to use the bathroom so bad, serious bowel movements, vomiting and stuff. But I believe in my mind, I'm asked to drink water. I'm asked to rest. And those are the two natural things that I can do to ensure that I'm helping my recovery and to combat what could be side effects. I don't know. If there's anything else, then probably, you know, the doctor would have to tell me so that I can follow that path as well.
Perfect.
I don't know if
See,
I've
on
answered
that,
the question.
that was fantastic response. Thank you, Marlene. I don't know, Sarah, did you want to add anything to that?
So when we know that a lot of the blood donors in Canada look more like me, and people with sickle cell tend to look less like me. So our blood is a little bit the same with antibodies and proteins on the surface of the blood, making them look a bit different. Because of that, we're really proactive in doing extended testing to make sure we get the best blood for the best person. And so that helps prevent, but not perfectly. Allergic reactions do happen and are really hard to predict when they're going to happen. The apheresis exchange transfusion is like a dialysis machine. It's not a dialysis machine, but it's like a dialysis machine. And it spins the blood really fast through a centrifuge spinner in the middle of the machine that allows us to separate out the red blood cells. So, you know, the person's blood goes through the system and we take out some blood and put in new blood. But as you go through treatment, some of the blood that's being taken out is the blood that we gave you earlier in the treatment. And that's
Mm,
why you had 8 bags, because, you know, a blood volume in an adult is about 4 to 6 liters. But during the course of the treatment, we are taking out your sickle blood, but also some transfused blood, which is why that happens. And the blood thinner in the bags of blood can bind calcium in the body and make the calcium swing, which can cause like muscle cramps, as well as a number of other side effects with blood pressure and bowels and things. So it is an exhausting treatment.
mhm.
You feel better because your blood is better, but the actual, like, I've just had my blood volume sucked out of my body into a machine and replaced a few times is kind of exhausting. So most people need to go home and rest. And I'm not surprised that it's not a walk in the park, but it is a really important and safe treatment. And just to jump in about the iron overload,
Right.
apheresis tends to be iron neutral in theory, because the blood that I'm giving should balance the blood I'm taking out. The exception is if you're a little bit low hemoglobin going in, so I'm bringing your hemoglobin up, then you're getting a net increase in blood hemoglobin, and that comes with iron. So exchange transfusion in theory, iron neutral, but we watch really closely anybody with sickle cell because iron happens for many reasons.
Beautiful. So on that same note, Sarah, will it be okay if we share your deck with the audience members? Beautiful. So I saw a question in the chat that's asking that, so we can definitely flip it over to you. Another question in the chat. Sorry, Marlene, did you want to respond?
Yeah, sorry, quickly. No, I just want to raise something for the benefit of those who have never undergone transfusion, just to say that the process can be up to 4 hours long, sometimes a little longer, depending on your reaction. I
Thank
don't
you for
believe
that.
I'd mentioned that.
You
So
didn't.
I've
Yeah.
had instances where, you know, I've been at the hospital for quite a number of hours, especially if I have to do blood work in the morning. For whatever reason, sometimes they're not able to accommodate me the day before. So I have to go like, say, 7:30 in the morning, do my blood work, and then wait around for probably like about 9 o'clock to do the transfusion. So there are times when I'm at the hospital for like 6 hours or so, right? And I just thought I would just mention that briefly because I omitted it. Thank you.
No, thank you, Marlene. That's a great point. I also want to mention, folks, soft plug in my so Skego is my passion full-time job. So it's my evening and weekend job. But in my 9 to 5, I work at Heart and Stroke. And to your point, Marlene, I'd be remiss if I didn't bring to attention the signs and symptoms of stroke. And you pointed them out very, very clearly, Marlene. You know, face drooping, inability to raise your arm, speech being slurred, and time to call 911. It's the fast kind of signs and symptoms approach. Now, granted, not everyone is living in an urban area or a metropolitan where 911 services are available, but we do ask that folks immediately try and activate some type of emergency measure when you do come up with those symptoms. And to your point, Marlene, I am very happy you did not go back to sleep, because that would be against the protocol I just outlined. So I'm just want to let folks know I'm going to post a link to that toolkit. And it's imperative that we do make sure this information is, shared broadly, because there are many folks who may be unaware that these are the signs of symptoms of stroke. So back to the question list. Shameless plug. Sorry, thank you for allowing me to do that. So Dr. Patterson, or Sarah, sorry, Sarah, does sickle cell leg ulcers, do they get completely healed, or how can they be managed?
So leg ulcers are challenging. They oftentimes the number one thing that we need to manage a leg ulcer is really good wound care. We want to understand how and why the ulcer happened. If the ulcer is caused by sort of inflammation in sickle cell disease, then we often want to do something to settle that down. If we think it's related to hydroxyurea, which in my experience hasn't usually been the case, but there are times when we'll hold hydroxyurea or stop it for a period of time to allow an ulcer to heal, but sometimes that increases inflammation and doesn't help. So that depends on the individual and the doctor. But prevention of irritation to the area to allow it to heal, really good cleaning, making sure it doesn't get infected. There's a balance between keeping it wet but not too wet, because that makes it more risky for infections, but not too dry that it can't heal and that tissue can't grow across. So definitely wound care and often wound clinics where people come and see nurses or have nurses come to the home is really important, and understanding why it's happening to try to take away the cause.
Thank you for that, Sarah. So there's a couple more questions. I want to try and see if we can squeeze them in. An attendee is asking, you mentioned treatment options such as gene therapy, and they're hoping to get approval. Like you mentioned, some of them are still underneath clinical authorization, I guess you can say, for integration into Canada. But can you please provide more details or refer to any sources for more information on this?
I think the SCAGO website's going to be
Exactly. I
great.
just want to mention that too.
More information will happen as we get more sort of information out. The treatments with curative intent, and I refer to them as treatment with curative intent for two reasons. One, because nothing in life is guaranteed. But the other one being that neither a stem cell transplant nor gene therapy is going to entirely fix damage that has already occurred. Many types of damage are permanent. So the avascular necrosis or the osteonecrosis, often once the head of that bone is collapsed and dead, it's dead and the treatment is a replacement. People who have certain lung or liver damage, it doesn't often reverse. So there certainly are risks and benefits to these types of treatments that are often very involved and involve really long hospital stays. But there's a lot of seminars and discussions that I've seen on those types of treatment. The risk of stroke post stem cell transplant with correction of the low hemoglobin, correction of the anemia, and reduced blood turnover and hemolysis does reduce the risk of stroke going forward. So there's some good data there. Small data, but that looks really promising. And those, as Miss Marlene Daly Scott told us about the toll on monthly appointments at the hospital, 2 visits, 1 for blood work, 1 for many hours for transfusion. Sometimes that therapy, while we think it's better, is a huge ordeal, and looking at some of these alternative therapies is important. We no longer have Oxbryta in Canada or the United States. It got pulled due to unacceptably high side effect risks. And we in my clinic have not had access to crizanlizumab. And Dari people have been buying over-the-counter L-glutamine supplements with some success. Nothing has had the documented research benefit of hydroxyurea or transfusion. But we're always excited and looking for the next thing because we want more options to be able to match the right treatment to the right person.
Perfect. Folks, I'm just including some links to some previous webinars. Thank you, Sarah, for responding to that question that speak to, hydroxyurea and other modifying therapies and some of the most current evidence supporting or helping to, raise awareness about what these entail. And I'm also going to share a webinar that we delivered with one of the first CAST-JV recipients in the United States who kind of walked you through their experience as well. And want to make mention that alongside one of our industry partners, we do plan on delivering a Learning for Life session that speaks to iron chelation and understanding what that, back to our point about the iron overload, some of the innovative, like you mentioned, curative attempts that are going to be put forward to hopefully relieve some of the symptoms there. So yeah, stay tuned, folks. We're bringing a lot of the information you're asking for to you. Sarah, to keep you on the docket, will a person who had stem cell transplant be prone to strokes? And if so, what precautions should they take in terms of medication or vitamins if they would still need transfusions?
So the hope would be post-stem cell transplant that you would not be at increased risk of stroke, related to the changes of the blood vessels in the brain from anemia, from low hemoglobin, or from that increased hemolysis blood turnover. So from that perspective, the stroke risk seems to settle down to somebody like with sickle trait, which is not thought to be increased over the general population. You would need to watch for other causes of stroke. So things like high blood pressure, smoking, heart disease in the family, irregular heartbeat or atrial fibrillation. And we had talked about that PFO, that patent foramen ovale, because everything in medicine is ridiculously complicated, which is a hole in the heart between the left and the right side that allows, if you have a blood clot from the venous side, the side where the blood goes from the tissue back to the heart, to pass over and go to the brain or other tissues like the liver or spleen.
Fantastic. Thank you, sir. So folks, just so you know, I've posted a poll for you to please submit any feedback about today's session. It's also an opportunity to hear more from you about any other topics you'd like to hear more from the SCAGO or our partners on in the future. I know there's one question here about if there's a recommendation to undergo a stem cell transplant. I think that's probably best for you to work with your caregiver / practitioner to understand your own personal circumstance and arrive at that decision. Probably wouldn't be able to do that effectively here on the call. Thanks, Sarah. Let me see if I think there's another question. No more questions here. I did have one question for you as well, Sarah, and then one more for you, Marlene. Sarah, you mentioned the preventative measures that your clinic with sickle cell expertise kind of has a wherewithal to undergo. Is that something standardized across Ontario? Do all clinics know to do those things?
They should. So
Okay, good.
there are so the Canadian Hemoglobinopathy Association is the national sort of association of doctors, nurses. We have some social workers, of people providing care in this space, and we provide consensus guidelines specific to Canada. Our last sickle cell consensus statement, I think, is from 2014, and we're just in the throes of getting the next edition out, and they provide Canadian-specific evidence-based medicine care. As well, there are guidelines through a number of other associations, through the National Health Service in Britain, the American Society of Hematology, and there's statements from Ontario Health, the quality statements that are important and try to get us to make sure we're providing culturally competent and appropriate care.
Beautiful. Well said. And so we only have 2 minutes left. So Marlene, I wanted to ask you the last question. What really impressed upon me is just your selfless nature. You said two things that I think were very profound. One, you didn't want to move your appointment at the off chance of disrupting somebody else's wait time. And two, you're sitting next to someone who's also going through transfusion, and you felt like you were living in that moment alongside them, that it brought you to tears. For our friends on the line, I mean, I know you're a woman of faith, but is there any other words you can give to encourage people that also may come up against these tough times of, how do you keep your spirits high?
Well, for me, like, you need to know your body. You need to know, right? I consider myself a low energy person. I work hard at work. And people say, I tell myself I'm lazy. And I've been saying that forever. My mom says you're not lazy. You work too hard. At work, they
You
don't
work too
think
hard.
I'm lazy. But I work so hard. And then by the time I reach home, I have no time, no energy for myself. Saying this to say that I know that I can't do much more than I have done already. So I pretty much live a low-key life. It's always work, home, and church. So know yourself. If you can't manage, you just can't manage. And don't be apologetic, because you have to take care of you before you can take care of anyone else. And if you don't take care of you, no one will be so concerned about you. So think about yourself first. The next thing, just think about others, right? You know the things, you feel, how, they make you feel. You know how you'd want people to treat you. Treat others accordingly. So if somebody's in distress and you can help. If you can offer a word of advice, a word of encouragement, a prayer, sometimes if they're not necessarily people of faith, you can pray outside of their area. We're not going to impose our faith on persons who don't believe. But because we believe, we will still go and pray for that person because we know what they're going through. So, things like those. And exercise. I'm not an exercise person, but I do believe there's some merit to it. So do whatever exercise you can, keep it moving. Doesn't necessarily have to be a run, a marathon. Just, even if it just means hands up and down, just keep your limbs moving. Because I've found that when I'm feeling pain and I try to move them even slightly, they improve somewhat. So those are some of the things that I would say.
Beautiful. On that note, folks, I just want to once again thank you to our panelists. Thank you, Sarah. Thank you, Marlene. You've made this a really inspirational, thought-provoking, and fulsome conversation. I'm so happy I had the privilege of moderating. To all of you who stayed on the line and were intent listeners, thank you so much for taking 2 hours out of your Saturdays to join us. As you know, the SCAGO is always trying to bring most up-to-date and timely information to you, and we couldn't do that without your interest and your participation. So without further ado, just want to once again thank all of you for being here with us this Saturday. The recording will be posted on the link I sent through in the chat. And as always, if you have any other questions, any desires, any needs, please do not hesitate to contact the SCAGO. We're here for you. Have a
Thank
wonderful
you for having
Saturday.
us.
Thank you, Sarah. Thank you, Marlene. And we'll
Thank you
talk
so
soon.
Thank
much.
you. Bye, everyone.
Bye, everybody.
Cheers.
Cheers.